one of the problems with cancer surgery is we're not always successful at completely removing the cancer. We have positive margins. That means we left cancer behind at the borders. And I became very interested in this problem back in 2007 when I was dealing with a particular case on a very young woman, 23-year-old, that got lung cancer. And she had a successful cancer operation at the time. We thought we had removed everything, and needless to say, 3 months later, it came back. It was very disappointing, and it made me wonder if there was a way we could have done something better in the operating room to have avoided a positive margin. We didn't know we had a positive margin. The pathology said it was clean, but it was clearly not clean. So I had an idea to see if we could make tumors glow or fluoresce, so that if the cancer cells were fluorescing or glowing during surgery, then you would not miss the borders of the cancer. You'd be able to fully get the borders and maybe even a little extra, and you knew when you were getting close to the tumor, because it's not easy to do during most cancer operations. And that was the basis of the idea of how to make tumors fluoresce.
Hello and welcome to Cure Talks. I'm Shweta Mishra and I'm thrilled to welcome you all today to this discussion where we will be diving into a truly remarkable development in the field of surgical oncology, the use of injectable diagnostics that makes tumors glow, helping surgeons see and remove cancer more completely. An approach which is a powerful shift in how we think about precision surgery and cancer care. Today, we have with us Dr. Sunil Singhal, William Moll Measy Professor for Surgery, Director of Center for Precision Surgery at Penn Medicine, and his research has led to the FDA approval of this glowing tumor technology currently used in lung and ovarian cancer surgeries and possibly more in the future. We are also joined by two inspiring patient advocates who will add patient perspective to this discussion. Amanda Hilty Richmond, a breast cancer and chondrosarcoma survivor, and a patient advisor with the Chondrosarcoma Foundation. We have Dr. Sydney Barnett, a physician and lung cancer patient advocate who serves as a passionate advocate for research, equity, and bridging the communication gaps between doctors and patients, especially during complex treatment decisions. I welcome you all to Cure Talks, Dr. Singhal, Amanda, and Dr. Sydney. It's an honor to have you all here on the panel. Thank you for joining.
Thank you.
Thank you.
I'll get started with a few foundational questions for you, Dr. Singhal. So could you help us understand a bit how tumor removal surgeries are conventionally performed, what challenges surgeons face with conventional methods, and how is this new injectable diagnostic helping improve outcomes and reduce the recurrence of cancer?
Hi, thank you again, Shweta, for the invitation. I'll tell you a little bit to back up and tell you a little bit about surgery in the U.S. for cancer. Each year, almost 1.5 to 2 million people get cancer in the U.S. And half those patients go for chemotherapy and radiation, but the other half go for surgery. So surgery is still considered a very important modality for cancer surgery, for cancer in the U.S. The role of cancer is surgery is critical in the care of the patient because a successful cancer operation can significantly improve survival. In fact, some data suggests that a successful surgery improves the patient's chance of survival almost 10 times than an unsuccessful surgery. So the natural question is, what's a successful surgery? What does that mean to have a successful cancer operation? A successful cancer operation really has three components. First, you want to completely remove the cancer in its entirety, and that's called achieving negative margins. So a positive margin means you left cancer behind where you cut, and a negative margin means you completely removed the cancer. Second, you want to find any additional cancers that may exist. So the cancer may have spread in the surrounding area, and you want to be able to find it. And third, cancers frequently go to lymph nodes, and you want to find any lymph nodes that may harbor some cancer cells in them. So those are the goals across almost all cancer operations, whether it's chondrosarcoma, breast cancer, lung cancer, breast cancer, prostate cancer, colon cancer. So one of the problems with cancer surgery is we're not always successful at completely removing the cancer. We have positive margins. That means we left cancer behind at the borders. And I became very interested in this problem back in 2007 when I was dealing with a particular case on a very young woman, 23-year-old, who got lung cancer. And she had a successful cancer operation at the time. We thought we had removed everything, and needless to say, 3 months later, it came back. It was very disappointing, and it made me wonder if there was a way we could have done something better in the operating room to have avoided a positive margin. We didn't know we had a positive margin. The pathology said it was clean, but it was clearly not clean. So I had an idea to see if we can make tumors glow or fluoresce. So that if the cancer cells were fluorescing or glowing during surgery, then you would not miss the borders of the cancer. You'd be able to fully get the borders and maybe even a little extra, and you knew when you were getting close to the tumor, because it's not easy to do during most cancer operations. And that was the basis of the idea of how to make tumors fluoresce. So as I started thinking about this, and we already knew how to develop dyes. There's lots of dyes all around us. When you look at a firefly at nighttime, that's a natural dye, bioluminescence.
Right.
There's all sorts of different dyes. Fluorescein is, and then also underwater, there's creatures that have ways to make dyes that fluoresce so the human eye can see. The second issue is, well, how do we get the dye to the cancer? And the field of targeted therapies was also getting very mature at the beginning of the century. And so the thought was, well, why don't we take a target and add a dye to it? And that combination would then be injected into a patient, and the dye would go to the tumor and make the tumor glow. So that's the concept. It's a dye attached to a way to target the tumor, goes to the tumor, makes the tumor glow. Wherever the cancer cells are, it's going to attach and fluoresce. So what we did for the next 10 years was work on these different approaches. And there's a tremendous amount of research that went into that, so I won't share all those details. But essentially, at the end, there were multiple products that came out. The one that you're most interested in, it sounds like, is the FDA-approved one. It's the only targeted FDA-approved agent in the country right now, but others are soon to follow. Others are very close behind. So the way this tracer particularly works, osteosarcoma. I don't know about chondrosarcoma, Amanda. I don't know if we've ever tested it. Lung cancer and ovarian cancer have a lot of folate to divide. So they use a lot of folate. And so what we essentially did was we took the folate and attached a dye to it. And so when cancer cells want to divide, they use a lot of folate, and that causes them to use the folate that's been tagged with this fluorescent agent, and the tumors start glowing. So what happens is, once you develop a new technology, as many of you probably know, there's clinical trials. So then we did a phase 1, and then a phase 2, and a phase 3 clinical trial. And it was really quite impressive, the results. We found with this agent, which is now called Cytolux, or paphlocyanine. If you look it up in the literature, it used to be called OTL38, the chemical structure. In the phase 1 and phase 2, we found that we could, in almost 40% of cases, which is quite a lot, 40% of cases, do a better job of getting the margins and improving the patient's outcomes, surgical outcomes, which is clearer margins, which leads to less radiation, et cetera. So we eventually did a multi-site trial, and what we found consistent results that we were able to better remove the cancers, find additional cancers that were not even presently, which were not seen on the CAT scan. So we realized this was more sensitive than even a CAT scan, the best modern day 1 millimeter CAT scans. This eventually, the other thing, by the way, we found was this technology was best for small cancers. Because the big cancers, you usually saw them on the CAT scan before you went to surgery. So if somebody had a 2 or 3 centimeter cancer, we knew going into it where it was. But if somebody had a small cancer, that's where we really began to make a big difference, because the surgeon's eyes couldn't always see it, the surgeon's hands couldn't always feel it. If there was metastases, the surgeon would miss it. And the fluorescent would highlight these additional cancers. So the results were very promising. And so we went to the FDA and they approved a phase 3 randomized multi-institutional clinical trial. It's 12 centers around the country. And these are some of the largest centers in the country, such as many of the large cancer centers around the country, academic centers. And the results in and this was a randomized study, blinded study, were even better. It's almost a 50% improvement in cancer operations. Lung cancer. Let me back up. Lung cancer. I'm a lung cancer surgeon, by the way. I should have introduced. I'm a thoracic surgeon, so I do lung cancer. So in lung cancer, we found that improved survival, and this was also proven then for ovarian. Right. And because of this was FDA approved. And what we found, just to give you the broad view of this, is about 10% of the time we would find extra cancers that were not present in CAT scan, and 30% of the time we would improve our margins. So that basically summarizes the technology to now, and there's other dyes and other aspects that you may want to
Yeah, thank you. No, that's a really helpful overview, doctor. And I can't imagine how incredibly powerful it must have been to witness that first patient that you saw this in. So thank you for all of that information. And I believe just one question that I have now, you have answered all my questions, and just wanted to know whether this technology does it work equally well across different cancers, or does it really depend on the tumor biology and the tissue biology? Can you talk a bit about that?
Yeah, that's a great question. So the folate's for very specific tumors that use a lot of folate.
Yeah.
However, the technology is moving very quickly. There are multiple tracers coming now that are targeted. There's a couple on the pipeline that are able to see more than 70% of cancer types. We, as a matter of fact, for example, now have soon to be starting a phase 3 clinical trial in sarcomas, because sarcomas do metastasize quite frequently to the lung. And this agent is feasible for every sarcoma type. So what we're learning is there's some common pathways that we can target. See, one of the things that makes this very unique is a lot of times you say, well, if we can target cancers, why don't we target them with drugs? But the problem is a lot of these targets are also present in the kidney or the liver. So if you target something toxic, you will hurt their kidney or hurt their liver. But for us, if we're targeting something in the lung, and the dye is also making the kidney glow because you're urinating it out, or making the liver glow because it's coming to the biliary tree, we don't care. it's harmless. And we're not working on the liver and we're not working on the kidney. We're working on the lung. So as long as we see the tumor glowing in the lung, even if it's going to the kidney and liver, there's no toxicity. It's completely safe.
Right.
So what we really need is that whatever organ we're working on, you want the cancer to glow and the normal lung not to glow.
Yeah.
And you don't care if the dye is making some other organ glow. And so the advantage of imaging or contrast agents or diagnostics, as you said, is that toxicity is less of a concern. Specificity and sensitivity, even specificity is not important, but sensitivity is very important. We want to not miss a cancer cell.
Right.
That opens up actually a lot of options for us on how we can target many different tumor types.
Mm. Thank you. Thank you, doctor. And that definitely gives us a lot to think about it in terms of future applications and also how it would benefit patients across a variety of cancers. At this point, I'd love to bring Amanda into the discussion, who has experienced the cancer journey firsthand and brings an important patient perspective to this discussion. Amanda, over to you.
Yes, thank you so much for this opportunity, and thank you for the work. I mean, like you spoke a little bit about the sarcoma, and I'm excited that you're starting to turn your focus on that because, as you know, sarcomas are pretty rare and don't respond. And a lot of times, like myself, you cut it out. Like you don't really have another option. So I guess to modify some of my questions, because you kind of answered some of them. So how do you find out if the institution is participating or leveraging your targeted dye? So example, I went to Vanderbilt. That was where I had my surgery. And how do you know? Like as a patient, how do you find out if they're participating in that?
Sure. There's multiple options. The first is, well, for example, at Penn, we have a center. It's called the Center for Precision Surgery.
Mhm.
You could just go on the website at the Cancer Center, click on Center for Precision Surgery, and you can get a list of all the cancer types that occur at Penn at least.
Right.
But it gives you a sense of all the different cancer types. I think we're doing 16 different cancer types now.
Mhm.
So ranging from bladder to esophagus to gastric to lung cancer, etc. For the Cytolox, it's already FDA approved. So it's not really a trial. It's surgeons who are using it. Anybody can use it in the country. And that's for lung cancer and for ovarian cancer. For clinical trials, there's a website called clinicaltrials.gov. And you can look up, one of the terms is called intraoperative molecular imaging. I'll say that slowly. Intraoperative molecular imaging. And I'm sure you would come up with multiple companies and that are each developing targeted dyes for different tumor types. I know there is, as we're doing obviously the phase 3 sarcoma, but if I had to think off the top of my head, I know there's trials now for breast, colon, prostate, bladder, a couple brain cancer types, esophagus. So there actually are quite a few trials ongoing. I think pancreas is launching or has already launched as well. So this technology is out there, and it's going to continue to grow year after year, and especially more and more companies are entering the scene. Back in 2011, there were no companies, and now there's I think 8.
So when did the drug first get FDA approved? The one that you were behind? Just out of curiosity. I don't know
Yes,
if you.
yeah. So so actually, I'm going to back up and give you one other story real quick. In 1990s, there was a dye called Gleolan. It was approved a few years even before our dye for brain cancers, gliomas. That is not targeted. It goes to a lot of places. So the difference was our agent was the first targeted agent. So that means it specifically went just to cancer cells.
Mhm.
And that was in 2022.
Okay.
But really at the end of 2022. It really didn't, I don't think it hit the shelf for another 18 months. So really it was in 2024 because supply chain and once the approvals, it took a while. So it's really been on the shelves, I'm guessing about a year and a half,
Okay.
and slowly being
So,
adopted.
so you're still obviously tracking to see the success rate of, again, if there is any causation versus correlation on having to do less cuts and any kind of reoccurrence. Like we're still learning because it's only been on the market for a year or so. Or are you still counting the 10 years you did the research too, in terms of is there a decrease because we caught it all with clean
Yeah,
margins? I'm just
yeah,
curious, like in terms of
yeah,
if you've seen any suggested decrease in reoccurrence because you are able to
yeah.
capture.
Well, we were actually getting ready to do these studies, but we actually had some funding cuts.
Understood.
So we have no longer been doing any long-term follow-up. So we've put that aside. So we don't have that data. We have had to choose which projects we want to focus on. So the project we're focusing on right now is developing a newer agent.
Mhm.
It's much brighter, so you can see deeper into the organ. For example, seeing deep into breast cancer is actually kind of hard to see.
Mhm.
So we're working on that. The other thing we're working on is making it right now for a lot of these tracers. Unfortunately, you got to come the day before. They take a while to circulate in your system. So you get the tracer, you go home. Or if you're coming from out of town, you're stuck locally. I mean, because you don't want to go all the way back home. But it takes almost 12 to 18 hours before the tracer goes everywhere in your body and latches onto all the cancer cells. So we're also trying to work on ways to make it so that you can get the tracer the same day as surgery.
Gotcha.
Um, Obviously, we're working on different ways to um, see different cancer types. And then the other big area of research, just based on my own training as an optical physicist, was trying to develop ways to to develop cameras which are even more sensitive, so that they can even pick up 10 cancer cells or 20 cancer cells.
Okay.
Right now, you need a good camera. There's three components. You need the dye.
Mhm.
You need the camera that's sensitive enough that has it's not, you can't just use an off-the-shelf camera. They're just not sensitive enough to see little cancer cells. And third, actually, you need good software to run these cameras. So these are all solvable topics, and it's actually one of the things that's been fun is developing these teams. And the teams like to get together because they don't work with each other very often. There's different, and it's also very motivating because we all have a common theme, which is to help patients, and specifically cancer patients. So a lot of times, you get people working on different projects, but when you hone in a bunch of people on a specific problem like cancer and cancer surgery, and you bring their expertise, some of these folks on AI don't work on cancer, but when you tell them about this project, it really gets them excited because they can make an impact on improving the software. And then I think the one thing I love about Penn here now is we've been able to create a great community around this. The Center for Precision Surgery. We have over 100 members now. We're the largest center in the world for this, and um, it's been fun putting these teams together and developing newer and newer, better and better technologies.
Okay. Well, thank you so much. I think
Yeah.
I'm good, Shweta.
Thank you. Thanks, Amanda.
Thank
Very
you.
practical questions. I'd like to now invite Dr. Sydney Barnett to share her perspective both as a physician and a lung cancer survivor and also ask her questions. Dr. Sydney.
Hi.
Hi, thank you for having me, and thank you for such a great overview on how this is actually going to be beneficial to patients. As a lung cancer patient myself, I found it very interesting. I actually believe that I know someone who benefited from this.
Okay.
She actually has had numerous primaries for lung cancer, and she went in based on what she describes. It sounds very similar to what you're describing right now. Went in, had this special dye, and it lit up an area that was not on her CT before, and this would have prevented her from having been diagnosed again. So it's definitely something that I think it's good for patients. And I think about it in regards to myself. I had a VATS procedure during my diagnosis, and when the surgeon went in, he thought everything was fine, that my pleura looked good. He took biopsies anyway, but I went into my oncologist's office thinking I was stage 3. And luckily, biopsies actually got some of the cells that were present, to actually have the oncologist tell me, it's unfortunately stage 4. But had he not done those biopsies, or had those biopsies not been in areas that were affected, then that could have been missed, and we would have proceeded with a stage 3 diagnosis, and then it actually would have been stage 4. So with that being said, is there any future with this technology being used in the earlier stages or in terms of diagnosis?
Yeah, thank you. Congratulations on getting through your stage 4 cancer. That's a scary diagnosis. So yes, actually, we use this for all stages. It doesn't matter. The stage doesn't matter. In fact, I would say more patients with early stage cancers come to us than the later stage patients. I think the later stage patients frequently are very nervous. They get their surgery done immediately at their local hospital, and they don't want to wait. I think as the earlier patients do a little bit more research, they tend to look for, they have a breathing room and they track us down. So we do a lot of stage 1 cancers actually, but we do stage 2s and 3s too. I don't think there's limitation. What's more important, but as I mentioned, the tumor, what we found was it's actually not the most beneficial for big tumors. Surgeons actually do a really good job, I realized, of taking out big cancers because you can feel it, you can see it, and you just take more. But it's like your situation where you have a cancer and it has a metastasis somewhere that's really small. And that's what many surgeons, especially in a lot of places in the country or the world, where it's not specialists doing these operations. When you come to a larger academic university setting, there's many more specialists who, for example, all I do is lung cancer, or I shouldn't say all, but I do a lot of lung cancer. But in a lot of centers, they don't. And so if you can improve a surgeon's decision-making and their visual sight at the time of surgery, you will improve their outcomes. You really don't have a huge, tremendous amount of downside because you can get a false positive. So something may fluoresce, but most of the time the surgeons can look at it and be like, nah, that's just reflection. It's the light reflection. They move their camera a little bit. Yeah, that was just reflection. So I think that there is a little intuition too that you pick up pretty quickly after 3 or 4 cases. And so the technology is good for any stage, any situation. And then I think the one situation maybe the least impactful is not so much the stage, but the depth. So if you have an organ and it's in the middle of the organ, the imaging cannot see that deep into the organ. It wouldn't be able to do it because it's visual. It has to be fluorescing. Now, the flip side is if it's that deep in the organ, you're probably taking out the organ. So you didn't need it.
Right. So, you mentioned the fact that, this was done at a lot of academic centers, but as we know, a lot of our patients are being actually diagnosed at community centers. So how do we, I guess, bridge that gap and make this something that's equitable to all patients that could use this sort of technology?
That's a good question. It's funny you should say that. 4 years ago, I had a postdoc from India come, and he showed up, and he just kind of showed up. I was surprised. And he says, I want to take this technology back to India. I said, okay. He says, I'm going to build the cheaper camera. And so he built the camera for $3,800. And I was so impressed. It worked. So we published it. We told people how to build a camera for $3,800 to see cancers glowing.
Oh, wow.
And so we are making it cost effective. Some of these dyes, because they're not biological, by that means they're not antibody based, they can cost less than $100 to synthesize. Now, granted, when they can cost thousands of dollars to the patient, because there's companies charge, they have to do R&D
Right.
but the actual synthesis is very cheap. The cameras are getting better and better and more commoditized, and there's many vendors. So I think that although there's like a lot of money to catch up on the money that was spent, ultimately this is not an extraordinarily expensive technology. It's a contrast agent that glows, and it's a camera that detects fluorescence, which is becoming quite common in every hospital in the country. That's not just present in big academic centers. So I do think that this will eventually filter through to a cheaper alternative. And I think that my prediction, and I don't know this, I mean, don't quote me on this, is as we get dyes that are more and more generic in the sense that they can see more and more cancer types, because of more patients, it's going to just get cheaper to mass produce these. Instead of, sarcomas are one of the tougher ones because there's less than 20,000 people in the US with sarcoma. So it's just not enough volume. So you really need to reap your reward from the R&D that went into it. But for bigger, more common cancers, you can get a lot more volume.
So my last question really is about how is this communicated to patients and, just how are we getting the word out there to not only patients but clinicians about the fact that this is possible?
I'm a little bit of an academic surgeon and scientist, so I spend probably more time in the laboratory. I think events like this are important, getting the news out. I think that the companies do a great job actually of marketing. That's part of their business is marketing and educating patients. I think that that clinical trials websites are good at attracting patients. I think that there's a tremendous amount of people who do work on marketing and advertising and informing the public. Mine has been more on the academic side, presenting in national meetings, educating surgeons at national meetings so they know about it. They get curious, they take it back to their home institution, they start talking to the vendors and saying, can you please bring in the dye so we can try it? So I think that there's a general movement towards commercialization of this agent. But it's really these presentations where people can read about it and learn about it.
Well, thank you for answering my questions. I don't think I have anything else to add.
Thank you. Thanks, Sydney. Great questions. And yeah, thank you everybody for this truly inspiring and insightful discussion. And the whole idea that, tumors can be made to glow so that they can be easily seen to guide the surgeons. It's just not fascinating, right? It's a real leap forward in how we are taking care of cancer patients, and also a reminder of the potential that innovation holds when it's done with the patient in mind. So thank you again, Dr. Singhal, for sharing your time and your groundbreaking work with us today. And Amanda and Sydney, both of you, thank you for your thoughtful questions to guide this discussion. And we also thank the University of Pennsylvania for the opportunity for this informative session. And to our audience, if you found this interesting and insightful, please do share with others who might benefit from it. And don't forget to subscribe to Q Talks at Penn to keep learning. Until next time, thank you everybody and take care.